Sawadee. My name is Phusayam Anurakwongsri and I'll be presenting the elbow dislocation part. So the elbow joint is both a hinge joint, which allows forearm flexion and extension, as well as a pivot joint, which allows forearm supination and pronation. And the structures that could be injured concomitantly with elbow dislocation includes the brachial artery, median nerve, ulnar nerve, as well as the radial and ulnar collateral ligaments and annular ligament, which forms the lateral collateral ligament complex. So there are many types of elbow dislocation. However, the most common type of elbow dislocation is posterior or posterolateral dislocation. These result from a combination of axial load that is transmitted up the forearm, supination or external rotation of the forearm, and valgus stress to the elbow. And a common example that can result in this mechanism of injury is falling onto an outstretched hand, as you can see in the picture. For the physical examination, inspection may reveal elbow deformities. Palpation can detect a palpable olecranon process in the case of posterior or posterolateral elbow dislocation, and the patient will have limited range of motion of the elbow. And elbow dislocations can cause injury to the brachial artery, so the brachial pulse, radial pulse, and ulnar pulse should be palpated. And after the pain and swelling subsides, you can use various special tests to assess for the injuries to the lateral collateral ligament complex and medial collateral ligament complex. As for the imaging, the plain film elbow in the AP and lateral views should be sent before.
What is this dislocation? What is this dislocation? What type? Anterior, posterior, medial, lateral. Yeah, postero. Lateral, very good. You look at the distal part. Distal part move posterior. In AP film, the distal part move lateral, right? So we call posterolateral dislocation. This is the most common elbow dislocation. Right? Next.
So the plain film is used to confirm the dislocation and also detect associated fractures, which are important for deciding the appropriate management for the patient. So elbow dislocations are classified into simple and complex dislocations. Simple dislocations have no associated fractures, whereas complex dislocations have associated fractures, such as radial head fracture, which you can see in the AP and lateral views for this picture, and coronoid tip fracture. And an example is what is known as the terrible triad injury, which is when there is an elbow dislocation associated with lateral ulnar collateral ligament tear, radial head fracture, and coronoid tip fracture. So acute simple dislocations are managed conservatively. Close reduction is performed under adequate analgesia and sedation. And after successful reduction, the neurovascular exam is repeated, the stability is assessed, and the plain film is repeated. And the patient is then immobilized with a posterior long arm splint in a 90 degrees flexion position for around 5 to 10 days. So this is an example of the supine approach for close reduction. The assistant will stabilize the humerus with both hands, and the physician will grab the patient's wrist and apply gentle inline traction, whilst also keeping the elbow slightly flexed and the wrist supinated. And the reduction is confirmed by hearing or feeling the kalunk sound. And this is another example.
Stop first. You see the dimple? Yeah, you always see the dimple in the back because the elbow is dislocated posterolaterally, right? So you need one assistant to hold the proximal, okay? And you hold the arm this way, okay? So let's say you stabilize proximal. So the elbow will be. So the elbow will be in posterolateral, right? Mostly. So first, after you stabilize the proximal, okay, then you apply traction And it's already coordinated. You need to supinate first. Okay, supination. You hold this way. Yeah, and then we do the traction. My hand will flap like this, and you see the thumb should be in the back. So 4 fingers on the proximal arm right here. So you traction, and then the thumb you push the thumb back. Okay. When you push it back, then you slightly flex. Right. You take the palm. Yeah. So traction first, and then supination. Adjust the mandible lateral because sometimes this stress lateral you need to put it in the same line. Okay. And then adjust and push this way and put this way. Okay. So that is the way to do the reduction. Okay. Show. You see? Traction, supination, and push. Okay. Traction. It's getting back. Yeah, see? Reduce. Yeah. And it will be stable when you bend the elbow. Yeah. When you bend, it will be stable. Some patients have the fracture around the elbow that will be unstable when they extend. Yeah. It will be stable when you flex.
So for the prone approach for close reduction, the physician or assistant will grab the patient's wrist and apply traction and slight supination to the forearm. And the physician will then use the other hand to apply pressure to the posterior aspect of the olecranon. So you can see him applying the pressure right here. And surgical management is indicated for acute complex dislocations or acute simple dislocations with persistent instability after reduction. And the operation of choice is open reduction with internal fixation and ligament repair.